Thank you for your interest in this discussion on mood conditions in patients with epilepsy. My name is Dr. Erica Meltzer, and I am a clinical neuropsychologist in the Comprehensive Epilepsy Center in the Department of Neurology at Northwell Health. My clinical practice is dedicated to working with epilepsy patients who have cognitive and mood symptoms often associated with their seizure disorder. Today, we will discuss the importance of considering all of the factors that affect a patient with epilepsy, including biological, psychological, and social factors. We will next discuss the most common mood disorder presenting in patients with epilepsy, depression. I will briefly review the relationship between epilepsy and depression, as well as how depression is diagnosed and treated. Lastly, I will discuss an important topic in the world of epilepsy, that is epilepsy self-management, or programs designed to help folks manage having a chronic medical condition like a seizure disorder. We will wrap up with a discussion of the role that the field of clinical neuropsychology plays in helping patients with epilepsy manage mood and cognitive symptoms. As we know, epilepsy is a disease of the brain that predisposes a person to recurrent unprovoked seizures. That is, seizures that occur with no clear cause. A person is diagnosed with epilepsy when they have 2 or more unprovoked seizures. Seizures are events that involve abnormal brain activity. Brain activity may become excessive or hypersynchronous, and this can typically be seen on an EEG. Importantly, the lives of people with epilepsy are affected not just by seizures, but also by many other things that can come along with seizures. And it's important to consider all factors that affect people living with epilepsy. Epilepsy affects individuals in many ways, of course medically, but also physically, cognitively, emotionally, and socially. Seizure episodes can be traumatic, and folks sometimes sustain injuries during a seizure episode. Medications can also have side effects and contribute to physical fatigue. Epilepsy also affects people cognitively, meaning it can affect thinking and ability to process information and remember things. Epilepsy also has an emotional impact. Depression and anxiety are common. And sometimes this condition also affects people socially, including relationships, independence, and opportunities, and felt social stigma about having epilepsy is a real concern. This image again highlights all of the factors that need to be considered when considering the whole person. This includes not only the seizures themselves, but also the individual's treatment plan, medication, or history of brain injury and medication compliance. Also, diet, sleep, thinking abilities, day-to-day activity, social support, and mood or the experience of stress are important as well. In many cases, a multidisciplinary approach to care is recommended, meaning patients with epilepsy often benefit from consulting a variety of specialists, including neurologists, psychiatrists, psychologists, social workers, and nutritionists. With the whole person with epilepsy in mind, it should be emphasized that depression is common in people with epilepsy. In the general population, depression affects between 5 and 10 to 17% of people. In comparison, about 10 to 20% of patients with well-controlled seizures have depression, and about 20 to 60% of patients with intractable epilepsy, that is epilepsy not well controlled with medication, have depression. The suicide rate is 10 times higher in patients with epilepsy than in the general population. Also, importantly, depression can make it harder to manage everything that a person with epilepsy needs in order to stay healthy, such as taking medications consistently and following up with doctor appointments. Let's now shift gears to discuss depression, the most common mood disorder in patients with epilepsy. It's normal for mood to fluctuate, to feel happy or content at times, but at other times to feel down, sad, irritable, anxious, or worried, especially in response to life's many stressors. Sometimes, though, low or depressed mood lingers and warrants attention by a doctor or behavioral health specialist. Clinical depression or major depressive disorder is the term that we use when depressive symptoms last 2 weeks or longer and affect functioning. Here I have listed various symptoms of depression, including loss of interest or the ability to enjoy things, weight loss or gain, increased or decreased sleep, motor agitation or slowing, fatigue, loss of energy, feeling worthlessness or excessive guilt, decreased concentration, or thoughts of death or suicide. While we often associate the word depression with sadness, hopelessness, and perhaps tearfulness, it's important to know that depression can show in different ways in different people. Some people do experience depression as feelings of sadness, moodiness, and irritability, or feelings of hopelessness, helplessness, or low motivation. Other people may experience depression more physically, meaning depression may cause them to feel tired all the time, to sleep too much or too little, or to have a change in appetite and eating habits. Still, others may experience depression as a change in cognition or thinking. It's common for folks who are depressed to report that their thinking is slowed or foggy. They may have difficulty concentrating, processing information, or remembering things. Depression does not always take the form of major depressive disorder or an episode of severely depressed mood. Some people experience chronic low-level depression. This is called dysthymia or persistent depressive disorder. It's diagnosed when a person experiences depressed mood for most of the day, for more days than not, for at least 2 years. Dysthymia is sometimes considered a milder form of depression than major depressive disorder, but it can be quite disruptive to a person's life. A person can also have chronic depression or dysthymia with more severe periods of depression or major depressive episodes. There are other types of mood disorders besides depression. Bipolar disorder is another type of mood disorder, and people with this disorder may have times when they feel depressed. Bipolar disorder is typically marked by extreme mood changes, including periods of emotional highs or mania and periods of emotional lows or depression. During periods of mania, people may experience increased energy and little need for sleep, euphoria, grandiose ideas, or irritability. Bipolar 1 disorder is diagnosed when a person experiences an episode of mania. Some people with bipolar 1 also experience episodes of depression or hypomania, a milder form of mania. They may also have periods of neutral mood. Bipolar 2 disorder is diagnosed when a person has had at least one episode of hypomania and one major depressive episode. Let's now think about depression as it affects patients with epilepsy. 1 of every 3 people with epilepsy has a lifetime history of a psychiatric disorder. Depression is the most common psychiatric condition in patients with epilepsy. With these 2 facts in mind, we can ask the question, why? What is the relationship between epilepsy and depression? A bit of history. In the 19th century, a physiological etiology for epilepsy was proposed. Later, research on the relationship between epilepsy and psychopathology separated along biological or psychological lines. There is a more recent renewal of interest in the neurological underpinnings of the psychological and emotional changes in epilepsy. Some of the underlying causes of depression are neurobiological. Seizures, subclinical sudden neural discharges, meaning epileptiform discharges that are not full-blown clinical seizures, and anti-seizure medication are all factors that can cause acute states of depressed mood. Also, feelings of depression often precede or follow seizures. And we know that complete recovery from epilepsy or complete seizure control can reduce a person's risk of depression. This is because areas of the brain that are important for mood functioning, such as the limbic system, are often also involved in seizures or a patient's seizure network. Lastly, some anti-seizure medications have mood side effects and can cause depressed mood or irritability. Mood symptoms and possible neurobiological causes of depression should be discussed with the patient's treating neurologist. The underlying cause of depression in epilepsy may be biological, as we just discussed, but psychosocial factors often play a role as well. With regard to psychological explanations for depression in epilepsy, having a seizure disorder is often very disruptive and difficult to cope with. Having to adjust to a chronic medical condition that requires frequent medical follow-up and monitoring, and that can affect one's day-to-day activities and independence can certainly contribute to depressed mood. In addition, people with epilepsy often have to deal with a lot of uncertainty. Seizures can be unpredictable, uncontrollable, and highly uncomfortable. This can cause a state of chronic stress and a feeling of helplessness or lack of control that can result in low mood. Lastly, unfortunately, The social stigma that is sometimes felt can be an additional burden. This, as we know, is sometimes related to the public not being informed or knowledgeable about epilepsy. Mood symptoms can actually present at all different time points for patients with epilepsy. They can present prior to a seizure, pre-ictally, during a seizure episode, the ictus, after a seizure episode, that is post-ictally, or between seizure episodes or interictally. The occurrence of mood changes just prior to a seizure is common and is often described as irritability or dysphoria. Depressed mood as a focal seizure has occasionally been reported. Post-ictal or post-seizure worsening of depressive symptoms is also quite common, and sometimes it takes time, hours to days, for people to fully recover mood-wise and to feel like themselves again. Next, we will discuss evaluation, diagnosis, and treatment of depression. An evaluation for depression is typically done by a clinical psychologist or a psychiatrist. That is a medical doctor trained in treating mood disorders with medication. This usually entails an interview or discussion with the patient to better understand their history and symptoms of depression. Sometimes a patient may also be asked to complete symptom questionnaires. Again, in order to be diagnosed with depression, one must have symptoms of depression for 2 weeks or longer that affect functioning. Unfortunately, there is no single diagnostic test like a blood test to diagnose depression. It is important for folks experiencing depression to inform their neurologist or other treating provider and to obtain treatment for depression. Depression is often hard to manage without assistance, and depression is a treatable condition. There are 2 approaches to the treatment of depression, and they are complementary and often used in combination. Behavioral treatment or psychotherapy is often the first-line treatment for mild to moderate depression. This entails working with a therapist during weekly sessions. Typically, a therapist will work with you to learn coping strategies and to better understand the feelings, thoughts, and behaviors that may be contributing to feeling depressed. Cognitive behavioral therapy, or CBT, is a form of behavioral treatment or psychotherapy that is effective for treating depression and anxiety. It is focused on the here and now and setting goals to start to feel better. Psychiatric care in the form of medication treatment is another way to treat depression. Antidepressant medication, specifically a class of antidepressant medications called SSRIs, selective serotonin reuptake inhibitors, is well studied and effective for treating depression. SSRI treatment is a popular treatment for depression and epilepsy. It's unlikely to increase seizure frequency or seizure severity, have few negative side effects, and minimal interactions with anti-seizure medication. But this should all, of course, be discussed with a neurologist to develop a good plan. Sometimes depression can be severe and can present with active thoughts of harming oneself. These thoughts can be distressing, particularly if they escalate, and a person feels a real risk to their safety and ability to manage. There is emergency care for this available. For such emergencies, you can call 911 or go to your closest hospital emergency department for care. Now, switching gears, we will talk about epilepsy self-management, a term that people may not be familiar with, and I'm glad to further explain. In 2007, with support from the Center for Disease Control and Prevention, the Managing Epilepsy Well Network was established. The Managing Epilepsy Well Network is composed of research centers across the country that have developed self-management programs. Self-management programs help folks with epilepsy learn ways to better manage their condition and improve their quality of life. Again, self-management refers to learning skills to help folks with epilepsy manage their disorder, as well as mood and cognitive difficulties that are common with seizures. There are different aspects of epilepsy self-management. One part is treatment management. This means adhering to medication schedules, keeping medical appointments, and communicating with one's doctors. Another part is seizure management. This entails knowing how to recognize and avoid seizure triggers and keeping track of one's seizures to be able to relay this information to doctors. Lastly, another important part of epilepsy self-management is lifestyle management. Part of managing epilepsy well is getting the best sleep possible, following a healthy diet, reducing stress, and having social support. Here at Northwell Health, we offer the Managing Epilepsy Well Network Self-Management Program, PACES. PACES stands for Program for Active Consumer Engagement in Epilepsy Self-Management. PACES is an 8-session epilepsy self-management program developed with direct input from adults with epilepsy at the University of Washington Epilepsy Center Health Promotion Research Center. It is run by a professional in our neuropsychology division and a trained peer who has epilepsy. Participants in the group are 6 to 8 adults with epilepsy and again, 2 group leaders. Specific PACES topics covered in the group sessions include managing stress and the blues, dealing with cognitive challenges, managing one's epilepsy care, and learning ways to talk to others about epilepsy and explain one's seizure condition. Participants also set weekly goals for themselves and track their progress. The first research trial on this program found that participating in PACES improves quality of life and mood. So now I'd like to talk a bit about the role of clinical neuropsychology in epilepsy care. Many people are unfamiliar with the field of neuropsychology. Folks have often heard of clinical psychology, a field focused on mood, emotion, and behavior. Folks have often also heard about neurology, for instance, that neurologists assess things like gait and reflexes. But fewer people have familiarity with neuropsychology, which is the study of the relationship between brain and behavior. The field of neuropsychology is dedicated to understanding not only brain functioning, but also dysfunction, problems with brain functioning. Clinical neuropsychologists assess cognitive abilities, mood, and behavior. The job of a clinical neuropsychologist is to identify cognitive strengths and weaknesses, assist in localizing brain dysfunction, identify mood or anxiety problems, counsel patients about cognitive and mood effects of their illness, identify risk for cognitive decline with surgery and help to preserve those cognitive strengths, and also to help patients learn ways to manage their illness. So in short, one of the major goals of practicing clinical neuropsychologists is to bridge psychology and medicine and improve cognitive, emotional, and functional outcomes for patients with epilepsy. I'd like to conclude this talk with addressing some common questions that people often have about depression and epilepsy. The first question is depression in patients with epilepsy different from depression in people without epilepsy? This is a complex question, and unfortunately, there is no simple answer. Depression in patients with epilepsy is often multi-determined by a unique set of factors, including seizures, side effects of anti-seizure medication, adjustment challenges, felt social stigma, and chronic stress. Regardless, though, the criteria for the diagnosis of depression is generally the same in folks with and without epilepsy, and the treatment is also quite similar. A combination of cognitive behavioral therapy and antidepressant medication are often the most effective regardless of the precise underlying cause of depression, which we often cannot pinpoint with certainty. The next question that often comes up is, whom can I consult to address my mood symptoms? First, it is important to inform your neurologist about your mood symptoms. They are managing your care and understand that depression is often a part of epilepsy. Your neurologist will consider how this should be handled, including whether an adjustment to medication is recommended, and/or if a referral to a psychiatrist or psychotherapist would be best. Psychiatrists, psychologists, and social workers are also providers that help to treat depression. In general, informing any of your treating medical doctors about depressive symptoms is appropriate and important, as the mind and body are not separate, but rather interact, and many medical or physical conditions can affect mood. To summarize, it's important to consider the whole person with epilepsy. Depression is common in patients with epilepsy due to neurobiological and psychological factors. Cognitive behavioral therapy and medication can be helpful for treating depression in patients with epilepsy. And epilepsy self-management programs are also available and can help patients with epilepsy learn coping strategies. Clinical neuropsychologists in epilepsy centers are available to provide guidance for mood management as well. Thank you for your time and attention. Our epilepsy service at Northwell Health is available to provide comprehensive care that addresses the whole person with epilepsy, not just the seizures themselves. with the goal being to improve mood and quality of life for our patients. Thanks again.